I'm honored to introduce you to the well-respected Dr. David Valhov, Dean and Professor at the University of California, San Francisco School of Nursing. He graciously accepted to speak as our keynote on late notice in the stead of Dr. Geraldine Bednash, who is the President and CEO of the A.A.N, American Association of Colleges of Nursing. She spoke highly of him as a noted researcher and scholar, a member of the Board of Directors for the A.A.N, as well as a fellow in the Institute of Medicine, a highly prestigious appointment. He brings in experience from interprofessional and interdisciplinary education as well as research, serving on the faculty as Professor of Epidemiology at Johns Hopkins, Columbia University, with adjuncts in medical schools such as Cornell, Mount Sinai, and New York University. Dr. Valhov is also editor-in-chief of the Journal of Urban Health, has edited 3 books on urban health, and published over 610 scholarly papers. As a keynote speaker with a wealth and breadth of expertise in the nursing field, we are all honored to have Dr. Valhov at our conference. Let's give him our warm welcome.
Forward, I just enter. Okay. Well, some people are coming in, and so I want to give them a few minutes to be able to do that. So let me try and understand the audience here a little bit, because Polly Bednash gave me a call here and said, please can you help me out? I have another commitment that came up that was very important, and so I said, fine. And as I was coming out here, I was thinking, wow, I heard there are 5,000 people as part of this, and that's pretty big. So how many people are here at Davis themselves? Davis people, okay? How many people are from the Sacramento metropolitan area? Yeah, if you're at Davis, you can raise your hand again. How many people here from California? All right, so everybody's California. Is there anybody that's not from California? All right, where are you from? Washington. All right. So coming quite a distance here. I hope you get your money's worth from my talk here, okay? All right. Looks like people have come in and sit down, and so why don't we get started here? What I'm going to be talking about is the change in the healthcare system. You're all hearing about health reform, and now the exchanges are opening in some states a little bit more successfully than others, but it's here, it's coming. And so with this change in how healthcare is delivered, I think it's a wonderful time to be coming into any of the health professions, but especially nursing. So if you're coming into nursing, this is a great time. You would be coming in where you don't have to relearn something. You get to enter into this new and challenging environment right from the very start. And so everything that you've seen on TV, in movies, read in books about what nursing is all changing. It's really, really changing. And so that's what I'm going to talk about a little bit this morning. So what do we have here? We have a demand for health professions of all kinds. This PowerPoint is the whole talk, all right? So after you hear this one, you can snooze. But I am going to have a little quiz for you at the end, so hang tight. So we got a big increase in demand, not just this year, but going on into the future. Sometimes you hear about, wait a minute, we don't have a nursing shortage right now. And some of that is related to what happened in 2008 with the economy. And so that took nurses who had been out of nursing for a while back into nursing. So if you had been working as a nurse and set up a consulting business and the consulting went down the tubes for a while there because of the economy, you might have gone back to work. Or if your spouse or partner lost their job, you might go back to work, right, as a nurse. So again, there were a lot of positions that were filled up because of that. The other thing is the healthcare system was shrinking because of the changes in insurance and so forth. The number of hospital beds that were being filled was fewer, right? So supply, demand, that was changing in the environment. But what we're finding is the economy's improving, right? People are going out looking at the other options. And we've got the health reform, which means that you've got 32 to 50 million more people entering into the system now, starting now. So we're going to have needs out there that are going to be fulfilled. The third part of that is that we have an aging population. And with aging come its challenges, right? So there's going to be a greater demand for health care to treat chronic diseases that come with aging. Not automatically, by the way, but that come. So we've got that transformation in the healthcare system, and that means we're going to have to expand who is an appropriate provider of care. So models of practice are changing. I'll talk about that a little bit. And I think it's exciting as it's going forward. So we're talking about transformation. And transformation includes a lot of different things. We're talking about alteration, change, conversion, revolution, renovation, right? All of these things that are, some think of as synonyms for transformation. But what do we mean by transformation in the delivery of healthcare? Well, again, the organizational frameworks are undergoing dramatic reformation and change, and a lot of that will occur with or without the Affordable Care Act. And so if you go to some of the states that said, you know what, we're not ready to participate yet, well, the changes are happening anyway. It may not happen in the same way, but they are happening. And what does that mean? What's going to happen that's going to be so different? Well, one of the things that we're going to be talking about is health reform, bringing more people into the system, but also creating systems of care. Now, in the past, we've looked at jobs, we've looked at functions as separate and in silos. So you might be hired by a hospital, and you thought of as the hospital as your system. And then there might be rehab and nursing homes, right? That was separate. And then there was community health, and that would be different. And so there would have to be some communications between each of these kinds of siloed organizations. In the new healthcare system, you have to be able to show that you're going across them. They're all part of one system. And so what we're seeing now is that organizations, medical centers, for example, are partnering with other medical centers and rehab hospitals, home health care, a number in public health departments. And they're looking at how do you take care of a population. So the old days in a hospital where a patient was being discharged, you'd have the person in the hospital room, you would have them leave in a wheelchair, even if they looked completely well. It's like, why are you doing that? But they did it, I don't know, risk management or something. And then they take them down to the front door, the sliding glass doors would open, and then take them and, help them into a car, and that was the end of their responsibility, right? It was sort of take a wheelchair and dump them on the curb kind of sense about it. And right now, you can't do that. You're not going to be able to do that anymore. You got to do the discharge planning, right? Where is the person going to go? And it's no longer going to be you write a couple notes on a sheet of paper and hand it to the person or their caregiver. You're going to have to think about where they're going and have people that create that continuity, coordination, and communication. And there are very few people that are in that role right now as the case manager, coordinator, going into the community. So again, that's an area for which there's been some service, but now the funding for that is going to change. Now, what do I mean by funding? Well, in the Affordable Care Act, you have a different set of incentives. The incentives that have been out there right now is the more you do, the more you get paid, right? So if I let you go, right, I discharge you prematurely and you come back into the hospital, click, you get to start the clock all over again and start treating the person. Well, in the new system, it's you got to take care of this person and what's happening to them when they're leaving, because you've got to prevent readmissions to the hospital. And if people are readmitted to the hospital, you don't get reimbursed. You don't get reimbursed. Well, that kind of changes the perspective a little bit. So that means you got to think about, have you taken care of the patient before they're leaving? Have you set up a system where they're going home or to another facility with adequate care, adequate response to their needs, right? So that's going to be something that's very important. And not everybody who leaves a hospital goes home and everything's great, and then they come back for a few visits and you've taken care of them. There are going to be some people for whom you need to think about palliative care, right? That's it. They're pretty sick, right? If you bring them back in, there's some times where a person comes back in and they shouldn't come back in. You know, they should be with their family and being treated with dignity. And so that becomes part of emphasizing the new sets of services that we have to develop, right? When a person needs compassion rather than treatment. So again, that's a different kind of thinking that's happening, right? So incentives there need to be lined up with what's going on. There are other incentives in this new system that's going to happen. One is the patient has to have a positive experience, right? Well, you know, gee, I hope so. But now there's a survey that patients fill out and they complete, and it comes back to the reimbursement organization at the government for the Medicare, Medicaid, and those actually get published online, right? So you can see how hospitals are going to be rated. That's one part. But another part of that is going to be that reimbursement's going to be tied to that, right? Partially, not completely, but partially. So again, the incentives are being different and outlined differently, right? Now, it also means that we're changing how we're dealing with the patient. And how we're dealing with the patient is, it used to be that, you know, the doctors and interns and residents and nurses would be a cluster of people that would go in front of a bed and talk about the patient as if the patient weren't there, right? And then they would, you know, and then somebody would write some notes and get back to you later and then go on to the next one. Now it's, what is it that the patient is saying? What is it? They're part of what that group is. It had moved from rounds to this concept called patient-centered care, right? We're all working for the patient, but were we paying attention to the patient at the center? And, you know, a lot of us do that kind of naturally, but now the incentives are also lined up with, is the patient engaged in their care? Not only was it a positive experience, but do they understand what's going on with the care? Are the providers actually hearing what the person is saying? in terms of what it is they're actually understanding about their care and what it is they're capable of doing. Do they have sufficient health literacy so that when a patient's being discharged back into the community, they have a firm understanding of what it is that they need to do and what their part is in what needs to happen, right? So there are providers out there that do that now. That's natural. That's something that we think about in nursing and nursing education. That's been a foundation. But the incentives have not been aligned like that. So if you go into a healthcare facility that has been a fee for service, then there's been more emphasis on get patients in, get patients out, so that the next patients come in and the next patients go out. And now it's going to be, wait a minute, let's make sure that everybody understands what's coming in and that people are carefully taken care of so that when they go out. Because what's the goal? What's the goal? Having people live independently in communities, right? That's what we want. We don't want you back in the hospital, right? And we want you comfortable having a positive experience, not only for you, but for the family caregivers, right? That's where things are. We all want that. We've all always wanted that. But now the incentives are lining up with that. And that makes it a deeper commitment and takes some of the other kinds of priorities shifting in terms of what's happening for care in these different settings. It also means lining up between these silos that have happened there before, right? Because now that becomes even more important. Managing risk and anticipating change, right? What I've just talked about, reactive care models, right? We take care of somebody, they go home, things go down the tubes, and then they come back in, right? We're really looking at how do we anticipate what's happening with the patient, with the caregivers, right? You have somebody with dementia, they're going home, they have family caregivers. Do you realize what the burden is for the family caregiver? I know some of you have relatives that have dementia, and it's wearing, tearing, beating up of the people who are the caregivers. They don't get enough appreciation, and they may not be getting enough support or respite in terms of what they're doing to be able to do their functions. So rather than waiting for everybody to burn out on that, it's how do we anticipate that kind of change? Let's not be reactive, let's be proactive. Knowledge explosion, right? So if you're going to go to Wikipedia, it says 40,000 clinical trials in process, and the clinical trials are creating new information that's out there that's going to help us change practice. So whatever you're learning in school, is in 2-3 years, the actual little factoids that you got they're gone. They're gone, right? Things have moved on. So what you're going to be learning in school is how to enhance your curiosity, how to have stronger discipline in staying up with information. And that is where nursing education has changed over the decades. In the past, students went to hospitals, were there for 3 years, and they learned all the procedures. And when they graduated, you had somebody that was, boom, on the floor taking care of the patients. Right now, people go to school, they learn how to think, right? That's more of the emphasis. How do you build critical thinking? And when you go into the healthcare setting, for the first year or two, you're fumbling around trying to learn the specifics, but that's okay. Because once those start, those you pick up, how to start an IV, I'll tell you, it takes 3 mornings and you're off and running, right? No big deal, on that one. But that's what we think about a lot. Oh, how am I going to give an injection and so forth? You practice on a couple oranges, and then, you're off and running. What you need is to sit there and to be able to look, what's the cognitive frame that I'm developing to be able to look at that patient, to sense, monitor, and react and develop with that person, right? So that's the bachelor's, the master's. That's going to be an important part of the education. Lots of facts, but it's really how do you organize it. So the old 3-year diploma nurse versus the 4-year baccalaureate nurse, what's the difference? Well, there's studies that have been out there, and they find that if you have a nurse with a baccalaureate degree, the mortality rate in those hospitals go down, right? Because you're bringing that in, you're anticipating, you're thinking that through. Education needing an overhaul. There are a number of ways that we need to think about that. One is patient demographics and desires, health system expectations, evolving practice requirements, right? Education we're building in to adapt to having not only recruiting for more diversity, but assuring that the education is addressing the needs of diverse populations. The changing healthcare system expectations, that's something of the theme of this whole talk. We're preparing not just for the bedside, but how is it that we think of ourselves in a healthcare system, even if it's just regional. You think healthcare system, the whole national picture, that's important to understand, to get, and you may eventually want to work in that kind of framework. But what we need to do is to think, how do I get a person from A to B to C so that we're all on the same page, getting the person to live independently in communities? Evolving practice requirements. With greater population needs, we're going to have a wider scope of practice. And so what we have to do is to evolve that. Now there's this group called the Bipartisan Policy Center, and they put out reports. The Health Professional Workforce Initiative was one of them. And what they're saying is we have to think about what's happening with the incidence and prevalence of disease in populations, right? In the last century, big emphasis on infectious diseases, now much more in terms of chronic diseases, right? A shift, an aging population. If you go back 10, 15 years ago, were people talking about diabetes and obesity as much as they are today? No, it's an emerging public health problem that's facing us now. That has to be built into the education. When I became dean just a couple of years ago, there were 3 clinical nurse specialist programs for diabetes in the country, right? And so now you're seeing these programs being developed in a much more organized way. It says environmental and lifestyle trends. We're going to talk about that a little bit more. Part of that is not just, we're all becoming more leisurely about what we're doing and, thinking about health rather than disease. It's how do we optimize ourselves? But it's also how is it that people are gathering information about themselves? So one of the challenges that we have is people who come in to see you that have studied their disease. They probably know more about it than you do just walking in the door. That's a very different kind of interaction that you're going to be having with the patients or the clients. Right? In the old days, it was, you're the expert and, tell me what to do, and you could make as many mistakes as you want. Nobody knew the difference, right? But now it's people are coming in smart. And number one, you have to respect that. The second is you have to come in at that level of information to be able to say, what are valid sources of information? Because if you go on the web and just start, reading around, you're going to find there's a lot of junk on there. Have people been reading, been learning things that are part of standard practice, right? There's some conditions where people otherwise would lose hope. And so there are a number of experiments that people are doing on themselves and, write about it as if that were equivalent information to what's out there in terms of traditional Western practice. May be good, you have to kind of sort that out, and sorting that out with the patient as opposed to just blowing them off, right? So again, patients coming in smarter on average and meeting them where they are. Delivery of care, again, it's not just the healthcare model that's changing. There are things like precision medicine. What's precision medicine? Precision medicine. All right, this is where you look at the genetics of a person, right? So for $100, you can go out, have a whole genome opened up for you, and you get a report says you're susceptible to this, and you might get that later, and watch out for your next generation and so forth. That's a lot of detailed information. And that used to be called personalized medicine because the idea is if you knew the genetic code, then you would be able to personalize the medicine to that individual. We know you're going to be getting diabetes. Let's manage this ahead of time. And if I know the personalized genetic code, then what I can do is make better diagnostic tests, and I can also start to shape what I'm doing in terms of treating that person. Precision medicine takes that a step further and says you have the environmental factors as well. What a shocker, huh? So you have the environment, you have the genes, you're putting them together, diagnosis, treatment, but for nurses, we also look at that for assessing and managing symptoms, right? That's a lot of what nursing needs to be thinking about. Changes in the structure of the delivery system. Again, we've talked about that in terms of clinically integrated systems. Changes in payment and incentives, I've mentioned that a bit already. And again, it's consumer expectations. They want to live at home, right? They don't want to be stuck in these hospitals. Consumer expectations, electronic health records, for example. Right, we used to write these charts, go down to the record room, stuffed with paper, and nobody's allowed to light a match, believe me. So now they're moving to electronic medical records, and the idea is that's more compact in terms of the data that you're going to be able to do. So that is something that patients now want to be able to get access to their own records. And in some places, such as the Mayo Clinic, they actually contribute to the medical record. They're allowed access in a special service to be able to write notes on what's going along so that in between visits you have information and data that actually makes for an engaged patient. Again, I talked about changes in cost and financing. We want to have something now that's very important to you, so give me a couple of minutes here. Because what we're going to have is continuous growth, right? We talked about maybe the shortage has kind of worn off a little bit, and we have enough nurses. There's going to be job growth. Again, we talk about 1998 to 2008, there was growth, and an additional growth expected through 2018. We've got some figures here. Physician supply and demand. You see the demand as the blue line that's going up, and then you see the one underneath where it's curvature, right? So the supply is not keeping up with the demand. More patients, older patients, more people into the healthcare system, but we don't have enough physicians. So There are a couple ways. Let's make more medical schools. Let's make more physicians. Let's bring physicians in from other countries. I worry about that because the other countries need physicians also. So what is it that we do with nurses? Well, what's the biggest growth that we're seeing in employment? And the top line is the nurses, and the lower line there is the home health aide, right? And this is another way to look at it. The dark blue line is the positions needed. The light blue line is what we've got there. So you see they're overreaching in terms of what the need is for nurses, nursing aides, orderlies, attendants, and home health aides. Largest growing business today is home health aides. One of the things in terms of being able to do that is looking at a long recognized need, and that is you have physicians, you have nurses. Physicians used to take care of patients individually, the great hero, Marcus Welby, and then you have other people that are assisting. That has to change. It is changing. It's part of our educational models where you're developing teams and you're looking at role differentiation. What is it that everybody brings in order to make that profession more effective as well as united with the other ones? So we have to reconceptualize the practice, care teams, interprofessional practice, performance measurement, and application of decisions in terms of how we're doing design, roles, and tying that into reimbursement. So much more focus on accountability of the providers working together as teams. So a team, let's look at teamwork, right? To give you a sense of where it is. By the way, nurses are on top there, right? Okay, I am looking at expanded roles for all. Right now, a number of states have restricted scope of practice laws. These are starting to change because the need is there. More people are being insured, being brought into the health system. You see there's the physician shortage. We need advanced practice nurses. And again, it's increasing the workforce supply. And again, you increase competition, lower prices. So we want the federal government to provide bonus payments to states to improve their scope of practice laws. And that is something that is a little bit different. Advanced practice registered nurses, there are 4 kinds that we talk about. The nurse practitioners, so it's nurse, BS, and then there's a master's degree or a doctor of nursing practice. That is so people work in primary or acute care. They're the nurse anesthetists, the nurse midwives, and the clinical nurse specialists. And the nurse practitioner works with the patient. Clinical specialist is looking at practice among a group of people. So again, 2 to 4 years of graduate education on top of the 4 years. So what are the challenges? Again, leading in this area of change of scope of practice means we have to engage in policy, collaborate across and within the professions, right? There are the rules, but the organizations have to align with the rules. There are incentives now for doing that, but we all have to work together in terms of the policy. As nurses, we lead, we follow, and we want to create policies that shape our future, and that depends on collaboration across the professions to find a common place. At UCSF and at many other places, we now are moving more and more towards the interprofessional models where we're having people looking at being in the classroom at the same time, learning not only the content, but also thinking through what are the roles, right? Because that's where you make the difference, and that, I think, makes for an exciting future. Thank you. Question?